Hello, everybody. I'm Roland Say, a general urologist at the Mount Sinai downtown and Beth Israel. And today I'll be talking about benign prostatic hyperplasia, BPH, and prostate cancer. And this is part of the Brookdale Geriatrics and Palliative Medicine workshop for 2024. All right, I have no disclosures. The objectives of my talk today are going to be understanding the physiology and developing an algorithm for initial management for BPH, and to also understand modern prostate cancer screening and guidelines and treatment options. So how we'll do that, this overview for our time today. For BPH, we'll go over definitions, talk about epidemiology and pathophysiology, symptoms and diagnostic workup, review some treatment options such as medical therapy as well as surgical treatments. And for prostate cancer, we'll talk about PSA screening and talk about some of the controversies and kind of up-to-date strategies that we use to identify and treat prostate cancer. So starting off, what is the prostate? Prostate is a walnut-sized gland at the base of the bladder. It's a sex organ that produces fluid that transports sperm during ejaculation. And the prostate grows to its normal adult size when a man is in his early 20s, stays stable, but then it continues to grow again once more, beginning in the 40s. So there are various things that can happen to the prostate during the course of a man's life, including prostatitis, benign prostatic hyperplasia, as well as prostate cancer. The prostate is generally divided into different areas anatomically. When we as urologists think about it, there are two kind of most relevant areas regarding these topics today. The peripheral zone, which is at the posterior apex of the prostate, that purple at the bottom, that's where 75% of cancers tend to arise. And that's also the area that is best felt, really the only area that's well felt on a DRE. And the reason that the DRE still holds some value is probably because that area is where the majority of cancers arise. And the transitional zone is the pink area in the center there, and that's where the BPH typically arises from. And it also is the area that surrounds the prostatic urethra. So you can imagine as things grow in that area, it can cause symptoms with urination. So talking about how patients are affected by growth of the prostate, there are different terms that we use. Some of them are overlapping and can mean similar but slightly different things. So BPH is truly a histological definition. So these are changes that are seen at a microscopic level, and that's the nodular overgrowth of normal prostatic glands and stroma. And then kind of at a more macro level, we use the term benign prostatic enlargement. And that's just if on a measurement like an ultrasound or on palpation even, it feels like the prostate is much larger than what's typical. That's the term that we use. And then in terms of clinical manifestation of symptoms, we use the term benign prostatic obstruction to define evidence of obstruction in the urinary flow because of the prostate. And then the kind of catch-all term for urinary symptoms that we use is this lower urinary tract symptoms, basically anything involving the bladder. We use this term, and it doesn't always have to come from the prostate. So BPH, once again, this is a histological diagnosis. It's a non-malignant enlargement. What happens because it's around that prostatic urethra, it elongates and compresses the urethra. You can see in that bottom picture there on the right, the nodular growth is compressing the urethra. And this happens to various degrees and doesn't always correlate with the size in terms of what the patient experiences. I see men with 300-gram prostates who claim they have no symptoms at all. And we'll see men with 30, 40-gram prostates who are miserable. So the size alone does not dictate the symptoms. BPH does get more and more prevalent as men age, as the population ages. You can see here, this is on the autopsy studies, looking at the prostate. You can see men in their 20s, 30s, very, very low incidence of BPH or prevalence of BPH. And as you get into the 40s, it's about 20%, 50s, about 40%, and on up. until you hit, the 80s, the vast majority of men are dealing with this to some degree. So how does BPH happen? It's multifactorial. There are a lot of things that go into it. The age, of course, as we discussed, is a factor. There's genetic components, hormonal components, etc. In terms of the hormones, this is part of the hypothalamic pituitary axis, involving testosterone. As you know, the pituitary stimulates both the testicles as well as the adrenal glands to produce testosterone. The vast majority is produced by testicles under mediation of luteinizing hormone, and the testosterone ultimately affects the prostate growth. How does that happen? It really responds to actually the secondary derivative of testosterone called DHT, or dihydrotestosterone. That's the main androgen that's responsible for prostate growth. That conversion is done by an enzyme called 5-alpha reductase, and there are two isoenzymes of this, both peripherally as well as within the prostate, and that's what we target with some of the medications that we use. So why do we care? And that's because BPH can really affect patients, affect the quality of life. So this chart here shows the prevalence of certain symptoms that men experience who have BPH. You can see 30%, 20% are doing things like being really, really careful with their fluid intake, having to change where they're going because of the availability of bathrooms, not being able to sleep enough, avoiding engaging in social aspects like playing sports or going to church. So it really can affect men profoundly. How do we quantify this? There are some validated questionnaires that we use. The most common one that we use is this AUA, International Prostate Symptom Score, or IPSS score. It breaks down lower urinary tract symptoms into two broad categories. The first is irritative or storage type symptoms, and those you see here. And the other half is these obstructive or voiding type symptoms. Those are the ones that we think most commonly are associated with prostate enlargement, are those obstructive symptoms. So hesitancy, straining, slow stream, intermittency, so stopping and starting of the stream. When we quantify this, we can get broad ranges where we classify the severity of symptoms. So we'll say mild, moderate, and severe, and we use those to help guide our treatment decisions. Of course, there are some more red flag signs that we look out for, and these complications of outlet obstruction can cause more severe medical conditions or medical complications, and those have to be addressed more aggressively and more acutely. So those are things like urinary retention, whether acute or chronic, hydronephrosis, so really backing up all the way into the upper tracts, into the kidneys, collecting systems. That can lead to obstructive uropathy as well as renal failure, recurrent urinary tract infections, bladder stones can form, and there can also be persistent hematuria. So when someone presents to the office complaining of these lower urinary tract symptoms, there's a broad differential diagnosis, both GU and non-GU causes. For the urological causes, there could be something like scar tissue or urethral stricture, could be UTI, prostatitis, could be problems with the bladder, such as neurogenic bladder or overactive bladder, bladder stones, and then non-GU causes, medications, different medical problems causing, polyuria or behavioral conditions. The things that we want to make sure are not driving this, want to rule out are malignancies. So we want to always keep an eye on, is there a concern for prostate cancer? Is there concern for bladder cancer? How do we evaluate a patient who initially presents with these kinds of issues? Take a history, use that symptom score, use that validated instrument. A physical exam is useful. At times a digital rectal exam is indicated to get a sense of the prostate. Certainly urine testing, primarily urinalysis with reflex culture. And in certain situations, you may be interested in obtaining a serum creatinine or a PSA. What do we do as urologists when the patient comes to the office? We'll also use some additional tools such as a urinary flow rate or a uroflow. You see the chart here on the right, which shows It basically measures the flow over time compared to time of the urine, and we use the peak flow rate as a certain measure to help kind of determine, as well as the pattern of the flow, to help determine whether certain types of symptoms are likely to be present, certain types of issues are likely to be present. We also will check a post-void residual bladder volume. That's generally done with a simple ultrasound device, and that measures, after the urination, how much is left over in the bladder. We try to assess size of the prostate, whether with a transrectal ultrasound or sometimes abdominal ultrasound or other imaging modality, sometimes through DRE. And then there are other specialized tests that we use in certain situations. Urodynamics is useful to evaluate the bladder if there's concern for neurogenic bladder or overactive bladder. Cystoscopy is useful for looking for anatomical obstruction such as urethral stricture, and also to get a sense of the morphology of the prostate, as well as urine cytology, which is most useful if you're concerned about cancer, and that's that presence of really more of the irritative voiding symptoms. Obviously, if there's some blood in the urine, that's another factor as well. So how do we apply this to a real type of patient? So this is Mr. X. He's a 73-year-old male. He's got some allergies, no other medical problems. He complains of just a little bit of nocturia. He wakes up every so often at night. Urine stream's slowing down. He says, oh, it's not like when I was younger, but he still really isn't complaining very much. His exam is normal, and his symptom score is a 5, which falls into that mild range that was up to through 7. And this quality of life, which is kind of a summary of the symptom score, he says he's pleased. He would be pleased if his symptoms continue like this in the future. So what do you do for him? Have some options here, including medications, watchful waiting. And for him, that's kind of the best choice. He's pretty satisfied. He's not very bothered by his symptoms, and that's what we use as our guiding influence is what's the level of bother that the patient is experiencing? How much is this affecting their quality of life? For this patient, it's pretty minimal. So for patients, especially with mild symptoms, we often will reassure the patient, we'll educate the patient about potential progression of the symptoms, and we'll reassess him periodically. But typically for a patient who is having a minimal effect on their quality of life, we don't tend to try and intervene. So this conservative approach can even be applied for patients with more moderate or even severe symptoms. There are some other behavioral modifications they can do to be more actively managing it without the use of medications or surgical interventions. Those are things like avoiding, on a schedule, being mindful of fluid intake, as well as certain irritants like alcohol and caffeine, which can worsen frequency, treating other factors that can contribute to these symptoms like constipation, and minimizing medications that tend to worsen bladder performance. There is some chance of improvement even for patients with moderate or severe symptoms. This study was done at the VA, and they found that up to 40% of patients stabilized or even got a little bit better without, these were patients with moderate symptoms who didn't get any worse, basically over 5 years. So, if a patient is kind of hesitant to start any kind of treatment, I think that's an okay option as long as they understand, there is a chance things get worse, but there's also a chance things don't. So let's bring Mr. X back a few years later. He's complaining now of a little bit more nocturia. He's waking up a few times. He's having to strain a little bit, but otherwise, still no severe symptoms. The exam is unchanged. His symptom score, however, has worsened. Now it's 18. So that's in that moderate category. And his quality of life, which ranges from 1 to 5, score now is a 4. He's dissatisfied. So what do you do for him? So for this patient, we would recommend starting some medication, and our first-line therapy is typically an alpha blocker. So patients who are bothered by their symptoms, whether it's moderate or severe, this is when we start to introduce some either pharmacologic or surgical solutions for patients. We discuss all the options that are available, and the pros and cons. In terms of medications, there's a list here. These are the typical medications that we consider when starting patients on treatment for BPH. As I said, the first is these alpha blockers, and there's also another list, and we'll go through these one by one. So the alpha blockers, they're best at improving the flow of urine and reducing the symptom severity. So how they work, they block the alpha-1 adrenergic receptors, which are at the bladder neck and within the prostate. It relaxes the smooth muscle there to allow for improved flow. That smooth muscle accounts for about 40% of the growth from the BPH. So we do really believe that this stromal proliferation of that smooth muscle leads to a lot of the BPH type symptoms. There's no effect on the bladder contractility itself. There's no effect on the actual size of the prostate, and there's no real effect on disease progression. What it really does is it targets the symptoms. There's various medications in this class. Initially, it started out with these non-selective ones here on the left side of the screen, but now we have longer acting and selective, which are more selective for the bladder neck and the prostate specifically. Those are the ones you probably heard of a lot: tamsulosin or Flomax, alfuzosin, silodosin, and those have been associated with fewer side effects than the earlier medications. They're all equally efficacious, and the likelihood of improvement is significant. It's about 60 to 80% compared to 30 to 50% with placebo. And that leads to a reduction in symptom score from the patient reporting of about 30 to 50%. So it's quite efficacious. There are some side effects to caution your patients, primarily orthostatic or postural hypotension. That's worse with the non-selective alpha blockers than the selective ones. There's risk of retrograde ejaculation, dizziness, nasal congestion. There's also the intraoperative floppy iris syndrome, which is a concern if a patient is going to undergo cataract surgery. It doesn't necessarily increase the risk from the surgery, but it's something that they need to alert their ophthalmologist to if they're undergoing cataract surgery. So moving on to the next class of medications, these are the 5-alpha reductase inhibitors. And these medications mediate the conversion of testosterone to DHT, as we saw back in that earlier slide. The type 2, the intraprostatic one, is what's targeted mainly by these medication, and it blocks the conversion from testosterone to DHT, leading to shrinkage of the prostate tissue over the course of about 3 to 6 months. The medications names are finasteride or dutasteride. The dosages are listed here. They're best for patients with a larger prostate gland because it has that shrinking activity. So really, it's only indicated for patients with prostates greater than 40 grams in size, and it's most effective in patients with prostates greater than 60 grams in size. The finasteride and dutasteride show similar efficacy. The likelihood of improvement is similarly about 50 to 80%, with a reduction in AUA score that's slightly less, more modest, about 30%. But there is this reduction in progression of symptoms. So there's a reduction in the risk of future urinary retention and a decreased rate of progression to surgery. What are the side effects of this class of medication? The side effects include a positive side effect, which is treatment of alopecia. So some men will notice regrowth of some hair and reversal of male pattern balding. But there's also potential for some sexual side effects. It's a low incidence, but it can be bothersome, and that's decreased libido, difficulty with ejaculation, or even erectile dysfunction. It also reduces PSA when measured in the blood by about 50%, but it does not necessarily reduce the kind of risk of prostate cancer. So, we have to kind of take that into account when we're looking at PSAs. So if a patient is on a finasteride or dutasteride and you check their PSA, kind of have to do a mental correction for that reduction and double it, and then compare it to normal levels in order to determine if a patient needs further workup. There's been discussion of whether it has an effect on prostate cancer itself. There's arguments both ways. There's a chance it may slightly increase the risk of developing higher grade prostate cancer, but I think that's probably related to less detection because of the effect on PSA. Third, sometimes we use these medications in combination. There's a landmark trial called MTOPS, or Medical Therapy of Prostatic Symptoms Trial. And so here we use the men in the study were randomized into different groups involving these medications or a combination of medications. And you can see from the chart here, the combination therapy was significantly better and more effective at treating patients with moderate to severe symptoms. It did show both a reduction in symptom progression as well as an 80% risk reduction in urinary retention and a 2/3 or 67% risk reduction in need for surgery. Moving on to the next category, it would be alternative medicines or phytotherapy, herbal supplements. Patients are always asking about this, very interested in it. The most common ones are saw palmetto, although you hear patients speaking about all these other ones on the list here. It's a huge industry, billion-dollar industry. At current, with the studies that are available, the American Urological Association recommends that there's no supplement that has been shown to definitively improve symptoms. Generally what I'll tell my patients is, these things are unlikely to harm you, but they're not as regulated. They're not proven to be effective. If you feel like you're getting a benefit, and something you want to take, that's fine, but don't use it as a full replacement for medication if your symptoms are very bothersome. All right. Next, we have phosphodiesterase 5 inhibitors or PDE5 inhibitors. These are most well known for their use in erectile dysfunction, sildenafil or Viagra, tadalafil, Cialis, Levitra, etc. These relax smooth muscles in the penis, in the corpus cavernosum, but they also have the same effect in the bladder, neck, the urethra, and the prostate. So this tends to help, modestly with these urinary symptoms as well. And tadalafil, which is the longest acting, is FDA approved for BPH as well. And it did show an improvement, although modest, in lower urinary tract symptoms. And this was independent of presence of erectile dysfunction, it having use for BPH. Another factor that you have to consider is if there is any overactive bladder component to the patient's symptoms. It's common for it to develop with BPH over time. 60% of men with BPH do experience some overactive bladder. Theory is that the detrusor muscle experiences changes with chronic obstruction that cause it to be more susceptible for overactivity. So the main medications that we use to target this side of the symptoms, things like frequency and urgency, incontinence perhaps, we use anticholinergic agents, and they're useful. However, you have to be careful. If the patient has an elevated post-void residual, there is a risk of putting the patient into urinary retention. So these medications are things like pilterdine, oxybutynin. There's a whole host of them. I do like to use trospium a little bit more in geriatric patients, and that's because it's a quaternary compound, so there's less crossing of the blood-brain barrier. So I think there's less risk for the confusion, which is much more possible with the earlier or other anticholinergic medications. So you do have to be careful, especially in older population, as they may suffer from some of these side effects already, and you don't want to worsen them, like constipation, memory deficits, visual issues. So you just have to be careful. Another class that's perhaps a little bit more useful in this population would be the beta-3 agonists. That traditionally was always just mirabegron, although a newer medication, Viagra, has been released in the last number of years, 5 years or so. It's been approved for OAB. This doesn't have any of those anticholinergic effects, but instead it can sometimes raise the blood pressure slightly. It similarly can have a risk of urinary retention. So let's get back to our patient here, Mr. X. This time when he comes in, let's say he's back at 73, but he's got pretty severe symptoms. He's already on tamsulosin, he's taking finasteride. He's still waking up at night a couple of times. He still feels like his stream is really slow. He feels like he can't get all the urine out easily. He's got a post-void residual there of 200 and a max flow of 5 mLs per second, which is pretty slow. Severe symptom score. PSA is not a concern. And his uroflow is that kind of longer, flatter line there. That's a sign of obstruction. So for him, what do we recommend? So he's got pretty severe symptoms. He's already on a lot of medical therapy. Patient like this, we would refer for surgical intervention. So what are the indications for an outlet procedure? The primary one is failure or inability to tolerate medical therapy. Some patients just prefer that. They don't like taking medications. They prefer to have a surgical intervention. If there's any renal insufficiencies, so any impact on the creatinine from this obstruction, that's an indication to pursue procedure. If there's urinary retention that cannot, that's refractory. If there are bladder stones, recurrent UTIs, or persistent or recurrent hematuria, these are all indications to proceed with an outlet procedure. So BPH surgery has changed a lot over the years. Initially, all we had was the open, simple prostatectomy, as seen on the left, over 150, about 150 years old. We were fortunately able to develop some endoscopic techniques. The TURP is the kind of most tried and true technique, initially described in the 30s, but has gone through various iterations to become better and better with the technology that we have now. In fact, now there's over a dozen procedures that we can use to try to manage enlargement of the prostate. Most of these procedures are done endoscopically or transurethral, where there's some either removal or destruction, like ablation, using different types of energy sources, whether lasers, steam, water vapor. Now there's robotic surgery, other things to try and reduce the prostate size. And what's the best choice varies from situation to situation. So each patient, there may be a few options for them depending on their preferences, as well as their clinical scenario. Size of the prostate is something that we use to help guide us, as well as severity of the symptoms. So there are these minimally invasive surgical techniques. You may have heard of some of them. These are ones that can even be done in an office type setting or with local anesthesia. Things like UroLift, Resume, prostatic artery embolization. These are best used for patients with mild symptoms and small to medium-sized prostates, or patients who are not as great candidates for general anesthesia, or patients who just prefer to have a less invasive or less involved procedure done. And for patients who are non-operative candidates in any sense, you can also use a chronic Foley or suprapubic tube placement, or a chronic intermittent, or rather clean intermittent catheterization. So chronic retention can lead to irreversible bladder damage if untreated. We use these though they're so chronic urinary retention can lead to irreversible bladder damage if left untreated. We use these strategies to minimize that, even though they do have their risks. Indwelling Foley catheter or suprapubic tube are the least desirable because they carry the highest infection risk, but not all patients are able to perform themselves or have a carrier perform the clean intermittent catheterization. So what's the take-home message? Patients with mild symptoms, education and watchful waiting is the mainstay. Patients with moderate symptoms, depending on what their prostate size is like or the patient's preference for medication, use one of the first-line therapies, whether an alpha blocker or a 5-alpha reductase inhibitor. And in patients with severe symptoms, you can trial medical therapy, trial combination therapy, but these patients are likely, especially if they're young, are likely to need to proceed and progress to a surgical solution at some point. All right, moving on to prostate cancer, which we'll review now. Prostate cancer is a public health concern. So it's the most common non-skin cancer in men. It's 27% of all new cancers each year. 1 in 6 men will be affected over their lifetime. and that's just the ones that we diagnose when they're alive. On autopsy studies, up to half of men over the age of 80 have some occult prostate cancer. It does also, kill a significant number of men every year. It's the second most common cause of cancer death in men, while the the risk of death for any patient affected is low. It's so prevalent that it still causes quite a lot of cancer death. There's no cure for metastatic disease. So if a patient's affected by metastatic disease, it's just a matter of management rather than cure. And this is a slow process. The natural history of prostate cancer can span more than 10 years. So what's the goal when we screen patients for prostate cancer? We try to use, we want to detect across a healthy population. We want to identify individuals who have the disease at an early and treatable stage, but don't really have symptoms. And we want to identify the patients that are going to be affected by this. So what do we use historically and still today? The mainstay is prostate-specific antigen, or PSA testing. It's a glycoprotein that circulates in the serum, and it's produced by prostate epithelial cells. The primary purpose of PSA is involved in the semen, but because it's detectable in the serum, this is what we use to evaluate prostate cancer risk. But there are a lot of things beyond prostate cancer that can affect the PSA. Just having an enlarged prostate, or BPH, is the most common cause for elevated PSA, but urinary tract infection, inflammation in the area, sexual activity, perineal, trauma, like even riding bikes before the test, instrumentation, all those things can raise the PSA, and it's a transient rise rather than a progressive rise like what we see in prostate cancer. So PSA testing really started around 1980s. It was approved in 86. And as we've initiated PSA testing and widespread screening through the 90s, the rates of mortality from prostate cancer declined significantly. Then, of course, in 2011, there was the USPSTF recommendation that recommended against screening, which they later revised to a grade C more recently. And, we're seeing some effects of that now as patients start to present with a little bit more advanced disease again. However, hopefully, we're not seeing too much of an increase in the mortality. So, there's a lot of discussion because along with the diagnosis, we were more and more kind of aggressive in terms of treatment. And these treatments do have side effects as well. So we're always trying to balance, how do we ensure that we're treating patients who need to be treated, but we're not treating too many patients who don't need to be treated, who would not have been affected by this disease, but however, impart upon them the side effects of the treatment, like urinary incontinence, bowel side effects, erectile dysfunction, things that do carry a significant quality of life impact. PSA is an imperfect test. It does not have great sensitivity. It has slightly better specificity for prostate cancer, but we're using it as a screening test. So, where you set that cut point is, of course, will govern the overall, will govern, how many patients you end up progressing to the next test, which historically has always been biopsy, but now we have some other things that we'll get into to help us to identify patients that really need the biopsy. So traditionally, we use a PSA cutoff of 4. From this chart here, you can see, it's more of a continuum. There's no magical number here. So you're gonna, as you change that PSA threshold, you'll find, more men who have prostate cancer with higher grade prostate cancer. You're going to miss fewer of them, but you'll end up testing more people. So, you have to be mindful. If a patient is young and has a PSA that's, in the 3s, if they're 50s, I'll typically work up that patient, even though their PSA is less than 4. So does PSA screening save lives? There's a lot of studies that have been done asking this question. A lot of a lot of talk has been, a lot of debate has raged on about this. We'll go over a couple things real quickly, but there was an American trial that looked at 77,000 men. They concluded that there was not a benefit from screening. However, there was a lot of crossover in this study. Ultimately, 86% of the control population was screened. It was a bit limited in that regard. The European trial that we often talk about is this ERSPC trial. This was 182,000 men. They found that men who were screened were less likely, 30% less likely to die from prostate cancer. Um, and this was over the course of about 13, 14 years. So what are the screening guidelines? The current guidelines are that men should be informed of the risks and the potential benefits of screening, and then men who are in the age range of really 45, beginning at 45 to 55, up until about age 70, or a life expectancy less than 10 years. Typically what I do is I will follow the AWA guidelines. I offer all men between 55 and 70 PSA screening, and then men who have risk factors such as African American men, men with a first degree relative. I will start screening around 50 or 45, especially if men have a family member who had early and aggressive prostate cancer. I'll start screening in the 40s. So the USPSTF similarly advises that men 55 to 69 can undergo PSA screening, and it should stress that it should be a shared decision-making process with their doctor. So how do we get better, beyond the PSA? There's no real consensus on any of these other tests, but there's a lot out there. The things that I like to use the most, are PSA, kind of over time, related to age, related to some of these other risk factors, and as well as PSA density. And that kind of gets to the next point, which is the use of MRI. That's something that we use more and more now. It's become much more prevalent, and it's useful because it has a better sensitivity and specificity than the PSA alone. 89% sensitivity, specificity 73%. And it also enables us to use more technology when performing the actual biopsy and identifying lesions within the prostate that look concerning, look suspicious. They're given a specific score based on this PIRADS standardized score criteria, and that allows us to target those biopsies that allows us to target those lesions during the biopsy to obtain a better quality biopsy. So many studies have been done, kind of demonstrating the utility of this. There was better detection of significant cancers with fewer detection of insignificant cancers, and that we define as, Gleason 6 being these clinically insignificant cancers. So ultimately, it led to fewer biopsies and fewer overdiagnosis. Caveats, there's not as much standardization with these fusion biopsy systems. There's a few different platforms that are out there. There's some variability in terms of MRI reading, although that has improved greatly over the last 10 years. That's become more prevalent. It is a more expensive way to do things, that's certain. And we don't really know what happens if you see a lesion on the MRI and you just watch it and what will happen to that lesion. We don't really know that. We also don't know if a man has a PSA that's not elevated and you get an MRI and you see a lesion there, what does that mean? We don't really know that. So once we diagnose prostate cancer, typically we'll advise treatment if it's what we call clinically significant prostate cancer. So that's Gleason 7, whether 3+4 or above. These treatment options include surgery, radical prostatectomy, radiation therapy, as well as options like active surveillance or watchful waiting. Active surveillance is typically advised for patients with clinically insignificant or Gleason 6 prostate cancer, and in some men with favorable intermediate risk prostate cancer. There's also focal therapy treatments, and we'll talk about a little bit more. That's a little bit newer. So, as with all things with prostate cancer, there's a lot of shared decision making when it comes to deciding on treatments, and it depends on a number of things. Because prostate cancer is typically a slow-moving cancer, life expectancy, medical status really does play a big role in our treatment decisions. We talk about treatment approaches, risks of different treatments, risk of the prostate cancer that we found, concerns on the side effects of the treatments. You can see the risk stratification system that we use in this table here. So prostatectomy is a surgical removal of the prostate and the seminal vesicles. The vast majority of them now are done with a robotic platform, which has the advantages of less blood loss and quicker recovery. Patients typically spend one night in the hospital. There's better visualization and therefore improved outcomes with the side effects like continence and potency. So does treatment of prostate cancer prolong survival? The short answer is yes, but it takes a while. So there is a decrease in prostate cancer mortality and a risk of metastatic disease, but the benefit is out 10 years or more. So this was a study from Sweden. We have another study here in the United States called the PIVOT trial. Similarly, they found reduction in prostate cancer death, reduction in local disease progression or systemic disease progression. So in general, though, death from prostate cancer is uncommon, especially in lower risk disease. The surgical treatment does reduce mortality, but this was also a limited study for a few reasons. Perhaps in a healthier cohort, there would have been a bigger difference seen. Radiation therapy, there's different modalities of radiation therapy. List some of them I list here. Depends on kind of the dose schedule and the degree of hypofractionation of the radiation. There's also a combination with androgen deprivation therapy that's used for higher risk groups, whether intermediate risk or high risk. There's also brachytherapy, which is another form of radiation therapy using radioactive seeds that get implanted into the prostate. And those are sometimes used in combination with the external radiation therapy and hormone therapy as well. So quality of life after treatment, after prostatectomy, there's certainly a high prevalence of erectile dysfunction, and that tends to correspond with pre-surgical function as well, where men who already have erectile dysfunction are much more at risk for developing more severe erectile dysfunction after surgery. Similarly with continence, men who already have incontinence or have more urinary symptoms, older men are more at risk for having incontinence after prostate surgery. That can be up to about 20% at 2 years. For radiation therapy, we typically think that the side effects mount over time as the damage from the radiation builds to the normal tissues. Those include similar issues with erectile dysfunction, incontinence, radiation cystitis, radiation proctitis, bleeding. There can be development of secondary cancers, bladder cancer, rectal cancer, and those do happen over time. So comparing the two is very difficult. Generally speaking, the principles that we use when recommending treatment for patients, for younger patients, healthier patients, we favor surgical treatment because the burden of side effects is upfront when the patient is healthier, and there's still the option for using radiation in the future if there is a recurrence. And then for patients who are older or less healthy, we typically will favor radiation therapy or even watchful waiting or active surveillance, and that's because the amount of time for potential side effects to mount is less, so there's less risk of harm from those side effects. So watchful waiting and active surveillance are terms that we use where we don't take necessarily a active therapeutic or treatment strategy at the moment. The difference between them, watchful waiting is more like benign neglect, so you kind of don't address the issue or continue to monitor the issue unless it's changing. And then when you intervene, really the goal is for palliation. For active surveillance, this is what we use for low risk cancers and often for younger men. And it's a much more regimented program where patients are receiving regular PSAs, exams, now MRIs, repeat biopsies on a schedule. And the idea is that if there is progression of disease, we'll change strategy to a curative therapy. So we use active surveillance for patients with this kind of clinically insignificant or this Gleason 3 + 3 = 6. Some patients who have 3 + 4 low volume disease, we also will do it, and it involves that schedule like we talked about. What are the outcomes like? Something about 1/3 of patients will progress as early as 5 years from initiating active surveillance. But a good number of patients are still, free from treatment at 5 years. And also the impact on prostate cancer mortality is also very, minimal or modest at worst. So this is a useful tool, especially for younger patients who are wary of the side effects of treatment. So it avoids overtreatment. It can postpone these complications. You don't have the quality of life effect. The bad part about it, patient kind of lives with some anxiety of this cancer diagnosis that's not being treated. There is better long-term data now, but it does also subject the patient to more prostate biopsies and the potential for, missing the window of treatment if a patient were to progress and be lost to follow-up. So you do have to have a reliable patient who's on top of things, who will continue to follow up. Now, focal therapy is kind of a broad term for ablative therapies that are lesion-based, basically focusing on that one area of the prostate, or hemiablative, doing just half the prostate. There's a lot of ongoing studies for this. There's not a lot of great evidence that compares it to other treatment modalities, and it's definitely not recommended for high-risk patients, but it could certainly have a role for patients who are low or intermediate risk disease. So now, circling back to kind of elderly patients specifically, like with all patients, we should take into account their general health status. We should take into account comorbid conditions, how independent they are, their nutritional status, as well as their cognitive function. The general guidelines from the SIOG are to, treat them if they're healthy or have reversible issues, treat them like you would treat younger patients. But if they're more, kind of more disabled or have more comorbidities, then to really just try to manage the symptoms or offer palliative treatment. So this is their guideline specific to prostate cancer. This really summarizes what we talked about, and focus on early palliation if there are concerns. Now, for advanced prostate cancer, it's more of a kind of managed like a chronic disease. As we said, there's no cure for metastatic disease in prostate cancer. We always use androgen deprivation therapy, or ADT, for patients with advanced prostate cancer, and that's either with a GnRH agonist like Leuprolide or Lupron, or a GnRH antagonist. Sometimes orchiectomy is still used, although that's not as common anymore. There are a lot of new drugs now beyond traditional chemotherapy for systemic treatment. We still use chemotherapy sometimes, but typically patients will be started on second generation anti-androgen medications like abiraterone, enzalutamide, apalutamide, darolutamide. There's a lot of them now, and they've been shown to be effective. There's some other methods like immunotherapy or Siplusil-T, and some targeted radiation therapy with radioligand like radium-223. The median survival for men with metastatic disease is about 5 years. And the is expensive, there is a significant cost for each quality adjusted life year gained. So how do we carry this into the future? Like we said in the beginning, we want to screen smarter, we want to treat better. What does that mean? We want to detect, find a way to detect patients who really will have significant disease. We want to kind of risk stratify the screening, use more layers before determining who needs a biopsy, who doesn't. We're using new biomarkers. There's a test called with an exosome analysis that has been useful. Um, there's looking into genomic testing. There's looking to, DNA methylation of the tissue on biopsies, and then of course using MRI, using imaging modalities to try and help us make better decisions, and then treating better. So, how do we identify the patients that are going to be affected by this disease? How do we minimize quality of life impact from our treatments while preserving, oncologic control? So, finding the patients who are good candidates for active surveillance, or potentially, sending some of those patients for focal therapy if that becomes more of an option. And then, of course, for advanced disease, we have more treatments to try and manage that. All right. Thank you very much for your time. And please reach out if you have any questions or other follow-up. Thank you.